All right, you guys want to talk about some knee fractures? So knee fractures in kids, okay? So one of my other favorite topics is a tibial spine fracture, tibial eminence fracture. Have you all had a chance to see one of those? What was the mechanism?
High-grade knee sprain. It was a high-grade knee sprain.
Knee sprain. What was the child doing to make the sprain?
This was like a child. It was a 20-year-old girl.
Uh-huh.
And she had a motocross crash.
Motocross. Yeah, bike. I saw a bad motocross this year. I had a 16-year-old boy, same thing. In the American textbook, it says fall off a bike. But motocross, fall off the bike. But the most common reason I see it in New York is skiing. It's usually after the 3-day weekend in January or the 3-day weekend in February, they come back from the mountain with a tibial spine fracture. It's called different things. These all mean the same thing: tibial eminence fracture, tibial spine fracture, ACL avulsion fracture. And these are all distal. This is the classic old textbook classification from Myers and McKeever. Myers and McKeever were pediatric orthopedists in Los Angeles. Type 1 is non-displaced or hinged a tiny bit, hinged a little more, completely displaced, displaced and rotated. Non-displaced, the anterior lip hinged, completely displaced. So type 1 is non-operative, type 3 is operative. Type 2, because it's just hinged, the classic treatment was if it's hinged a tiny bit and you can be in full extension, then maybe a cast is enough. Or if it was hinged a lot, to try a cast, and if you can't get the fracture better, then go to surgery. So pretty much everybody agreed type 1 not operative, type 3 operative. And type 2 depends on if you get a reduction or not. Okay? So I looked at a bunch with some of my friends. I looked at classification trying to make a classification with MRI. And I think MRI, it's easy for me to get MRIs on all my knee fractures. Does anybody have trouble getting MRIs? Probably a lot of people. So I'm not saying you have to get MRI. I'm just saying if you have it, this is how we look at it, okay? So we want to see the fracture pattern. I want to see where it's displaced, and I want to look for soft tissue entrapment. And so this is what we came up with. So if it was less than 2 millimeters displaced, we called it grade 1. In grade 2, we saw a lot of patients that had like a 1 millimeter displacement. We didn't want on the MRI. So we modified this to 2 millimeters on each side. That's a grade 2. And then grade 3 was ones we had to operate on. So severe displacement in the back, greater than 2, meniscal entrapment, intrameniscal ligament entrapment, or these big fractures here that go into the weight-bearing surface. So I had an article, I think it was this year or last year, in the American Journal of Sports Medicine. The title was Tibial Spine Fractures Go Beyond the Tibial Spine. Because we see about almost 20% of these go into the weight-bearing surface. So if you're only looking at the lateral, you might miss some displacement in the weight-bearing surface. Let's go for a couple. When I started studying this, I found a lot of patients who were, I would almost call a type 0. You could see the fracture line on the MRI, but you couldn't see it on the X-ray. Grade 2, so it's non-displaced in the back, it's hinged in the front. Here it's maybe displaced a tiny bit, but not enough, so we still call it a grade 2. And then here you start getting comminuted and displaced, grade 3. Here's one where the meniscus is clearly entrapped in the fracture fragment. So now when we have the MRI, we can look for that. And this little dot's the intermeniscal ligament. And then here's one where You can see the meniscus on the body of the meniscus, so you know you're in the weight-bearing zone here, and you can see 2 millimeters displacement at the joint surface. So we basically, when using the MRI, we changed our plain X-ray classification over 30% of the time. And we had pretty good agreement. So the people are starting to use this a little bit. So 33% of the time, the MRI would change our treatment to either non-op or operative. Undetected fractures, sometimes it goes up and sometimes it goes down in terms of the classification. Meniscal entrapment is pretty important. How often does that happen? It's over 25%. So you can't always, obviously you can't see that on plain x-rays. So you have to have a high suspicion of that. So this is the little, that's our little MRI classification. So what about how to treat it? So if you decide you have to treat it, how do you guys treat tibial spine fractures? We got a lot of knee surgeons here, pediatric surgeons here. Come on, tell me how you're going to treat it. Sutures? Arthroscopic? So arthroscopic sutures. Anybody treat it open? It's, there's a lot of doctors that have good results treating it open. I don't treat it open, but when they compare open versus arthroscopic, it's not a big difference. But I like arthroscopic. Sutures, what else could you use besides sutures? You can use, you can use absorbable screws. I don't like big absorbable screws in the knee. It's my bias. Small little tacks are okay, but big absorbable screws, if they break off in the knee, then they can cause trouble as they dissolve. So I don't longer use absorbable screws in the knee, but I know many people do. Metal screws, absorbable screws. And so I still use both. If it's a big bone fracture piece, I like the screws. If the little wafers, I like the suture. But some people in the States always use suture or always use screw. It's hard. And I think there's a slight, definitely the majority of folks in the States are probably using arthroscopic sutures. But I think I have a bunch of cases here versus that I still use screws too. Okay. So what do? We gotta get the blood out of the knee. It takes a while. We have to see in the front of the knee more than usual, so we have to get the fat pad out of the way. We have to find the anterior horns, the intermeniscal ligament, and then we want to get the scope and the shaver and the camera under the fracture and try to get some of that callus and blood out so we can really get the fracture reduced. I think the key is, just like any other thing that we do all the time, is to get a good reduction. So I don't think it matters that much if you use suture or screws, but you have to get a good reduction. The other thing I try to do is sometimes the anterior lip of the fracture, I'll trim it a little bit. Just take a biter and make it a little bit smaller. Obviously, we're going to remove the entrapped meniscus. We're going to pull on it. Sometimes we can use a little hook or put a suture around it and pull. With the knee flexed, I use this tibial ACL guide, this sharp point, to push the fracture down. Okay, and then I often will put in a K-wire from up higher in the knee near the patella down into the knee to get it stabilized. Here's a hook I'm using through the portal to grab the meniscus and pull it forward, while with the other hand I'm pushing this down. I've already debrided underneath it. I've trimmed the anterior lip a little bit so it's easier to sit in the fracture bed. And then classic suture technique. I don't worry about the growth plate if I'm just putting sutures through a tibial spine fracture, because it's almost impossible to put the sutures epiphyseal. They don't really hold that well. So they go past the suture will go past the growth plate. And then you just tie it over bone or tie it over a button or tie it at an anchor. So there's 8 years old, pretty young, fractures going into the joint surface. And we prepare the bed. I'll do like a little microfracture here, or whatever you want to call it, to get the bed bred, and then here we go. So, what else? Here's an 11-year-old female, 6 days after skiing. We see the obvious fracture. She likes to do gymnastics and diving. Big piece, relatively big piece. Displaced, type 3. Intraoperatively, displaced. Meniscus is okay. We're pushing it down. The ACL behind it looks pretty good. Reduction's starting to look good. We have sutures passed. Sutures grabbing it and pulling it down. And then I tied it over a little button. Pretty good reduction. It's hard to get these reductions perfect, but it's really important because you want to move them right away and you want to get good range of motion. So what is some common complications of tibial spine fracture? Arthrofibrosis. How do you define arthrofibrosis? Right? Right, so then you kind of go, well, how far is too much? Most studies will say lacking 5 or 10 degrees of extension or lacking 20 degrees of flexion, around that. What is the rate of arthrofibrosis with the tibial spine fracture? It's almost 20%. It's very, very high. So we did some research in the American Journal of Sports Medicine. 4 things were linked to arthrofibrosis. 1 was use a cast. So never use a cast. Always do motion. Even the first week or 2, it's safe to move it if you have good sutures or screws. So always start range of motion right away. The second risk factor was age under 10. Third risk factor was high energy, like a car accident or a motocross accident. And the fourth one was, if you had an MRI, you could see the ACL had a partial tear to it. So those 4 things were shown to have an increased rate of tibial spine fracture. But I think the most important thing is you have to get a good reduction. You have to get a good reduction. If you have arthrofibrosis, and then you just aggressively remove the scar arthroscopically, usually 3-4 months after the first surgery, and most of the time the kid gets better. So we'll go. I use a lot of screws, usually for the bigger pieces. I did 2 this last month. So it's big going from one side of the plateau toward the other. And 1 big piece, big deep piece. I know this measurement. If I put a screw in, if I don't want to cross the growth plate, I use a screw less than 20 millimeters. I use a cannulated screw. Again, I reduce it with the ACL guide. And then with the knee in hyperflexion, I put a K-wire next to the patella on the medial, usually on the medial side, but it can be the lateral, and bring it to the tibial spine, and then make a little portal above our usual portal to put in the screw. With the K-wire in and a cannulated screw, it goes pretty quick. I usually use 2 18 or 20 4-millimeter screws that are self-drilling, self-tapping, so I don't have to drill, I don't have to tap. So it's in like a portal that's up here, above the usual portal, the knee's in flexion, and another entrapped meniscus. And these were put in from the superior medial accessory portal, 2 screws. When you want to sink these a little bit, and at the end you want to make sure that they're not impinging on the femur. So Here's another example. So the K wire is in. Here's a knife coming in to make the portal, and there's 2 screws there. So I like the screw for when it's a big piece. And we don't use the screws for smaller comminuted pieces. It's hard to get x-ray when you're putting the K-wires in, because the K-wires just, the knee has to be flexed. So you can maybe get a lateral, but you can't get an AP until you take the K-wires out. And then we always do early range of motion. There's some more. Here's one with 3 screws. So let's keep talking about knee fractures. So let's talk about the Salter-Harris fractures around the femur and tibia. So everybody knows this in this room, right? But one of the test questions I don't like is, but I'll go ahead and ask it. Which one of these has the highest rate of growth arrest? A 1, a 2, a 3, or a 4? They think the 4, right? But what's more important is what growth plate's involved. If it's the distal wrist, distal radius, and it's a Salter-Harris 1, 2, or 1 or 2, it's almost 0, 1%. But if you have a 1 or a 2 in your femur, it's almost 50%. So it's not just the Salter-Harris type, it's the location of the fracture. So around the knee, if you have any of these fractures, you have a high rate of growth arrest. At least 25%, in some literature up to 50%. Oh, here it is. So proximal humerus, rare. Distal radius, rare. Femur, 50. Tibia, 40. Distal tibia, 40. So we see here, what kind of fracture is this? We got a 9-year-old with a Salter-Harris 2. So how would you treat this? There's a couple different ways to treat this, right? So I heard a close reduction and what? Casting. I don't like casting for these because you have to almost use a spica. You have to use the long, you get a close reduction. You don't have rotation control that's great for the femur without a spica. I'm not saying for like a super baby stable one, maybe that was not displaced to begin with, but if you have to reduce it, I don't think casting alone is enough. So if you're going to do a closed reduction and you didn't want to do casting alone, what else could you do? You could do pinnings, right? And you could cross the growth plate. And that's a good choice. There's a pretty big Thurston Holland fragment here. Metaphyseal fragment. So what else could you do? You could screw it. And that could be relatively percutaneous too. And then you have to tell the family 50% chance of growth arrest. And you have to tell them before you do the surgery. You could put the screws, you could put these K-wires in any direction. I like, when they're skinny kids, I like to go this way so that when I leave the pins out for 3 or 4 weeks, that they're not in the joint. But you can do it in either direction. It's just that in the fat patient, you can't really do it this way. So we got a 9-year-old skiing, and this is just a terrible case that presented to Dr. Helfet, my trauma doctor friend. So a T condylar, crazy, with growth plate, young kid. And the initial reduction in the mountain was not so good. So kind of still displaced. So 3 weeks later, they took down the entire thing, and my AO friends went a little crazy. But you get good reduction, good stability, good range of motion. So now, a couple years later, we have a growth arrest. So what should we do now? Yeah, that's really, that's a young patient, so it's really in the range where you could do lengthening and it's a little too late to do shortening. They should have probably considered doing the epiphysiodesis a couple years before. The other side. Here's a comminuted. You know, these don't happen very often, but they happen. Here's a patient of mine with a comminuted plateau fracture and tibial spine. I think a motorcycle accident. The other thing around the femur and tibia is that sometimes the artery, if it's a displaced fracture, sometimes the artery gets tented or stretched, and you can get compartment syndrome and vascular problems. We know about the growth arrest. So all these kids, they'll feel good in 6 months, but you need to see them to look for growth arrest. Anybody see the AO reference app? AO trauma reference app? Well, I'm the proud editor of the femur fracture in pediatrics. So I recommend you click on that, and they have some very good diagrams too. So let's keep going. We go tibial tubercle. This is a unique fracture that really only happens in the kids, really. You know, a bony fracture of the tibial tubercle, and it's a real fracture. When does it happen? When do these fractures happen? It's sort of the same mechanism as a patella tendon rupture. It's often like basketball, jumping, eccentric loading, and they pull their entire tibial tubercle off. Have you guys seen those? What's the complication related to tibial tubercle fracture? Right, they have a terrible extensor mechanism. If they're young, it can cause a growth arrest, but they also have a pretty high rate of compartment syndrome, 5% to 20%. It's more than you think. Especially the ones that go into the joint. So the mild ones stay to the tibial tubercle, the severe ones go into the joint, and the ones that go into the joint can also affect the meniscus. So you have to get anatomic reduction, of course, if it goes into the joint. So here's a kind of a comminuted one, and that's limited to distal. On there you get an MRI. This one goes into the joint. So another thing about these is, even though this is one piece, you have to fix both pieces. You can't just put a screw here or put a screw here. When you're fixing these, you have to, if the ones that go into the joint, you have to fix the epiphysis, and you have to fix this part here too, the distal apophysis. If you just fix one, the other can displace or not. So please fix both. We'll occasionally use cannulated screws for these, but I'm not a big fan of cannulated screws because I've seen big obese patients bend the screw. Also, we've had about 10 cases in our hospital where you think it's a tibial tubercle, but at the same time it's also a patella, avulsion off the patella. So you can have a bipolar extensor mechanism injury. And we have almost 10 of these that we reported. So keep your eye out for that. If you see it, it's real. So you can see this part came off the patella. Probably the medial side came off the patella. The lateral side came off the tubercle. Here's the beautiful AO picture. So you want to get both of those fragments. Well, what about patella sleeve fractures? Have you guys seen that? Yeah. And so the thing about patella sleeve fractures is sometimes it's a whole sleeve of cartilage you don't even see. Right? It's hard. Sometimes people miss the diagnosis. Obviously, there's a high riding patella. This one's pretty obvious. So how do you fix that? It needs open reduction. It needs extensor mechanism repair. Very similar to what you would do with an adult with a patella tendon. The only difference is you have to be sure the articular cartilage is okay. So you have to kind of either stick your finger in the knee or stick a scope in the knee or look at the knee underneath the patella tendon, underneath the patella to make sure cartilage is okay. So patella sleeve fracture. Here's like the sleeve of where the patella goes, and there's a little cartilage there. Sleeve can be bony, articular cartilage, or just periosteum. Most of the cases don't involve a lot of articular cartilage, but some do. And here you can see the tear in this patient went on the medial side from the top of the patella to the lateral side. It's really a big zone of injury. So in addition to fixing the patella tendon part, I like to kind of sew this other part up too. You can see the patella tendon way down here. Don't confuse this with this apophysitis here, this Syndig-Larsen-Johansson syndrome. It's like the Osgood-Schlatter's of the patella. If the kid is able to do a straight leg raise and then the pain's not so bad, it's not a sleeve fracture. So we treat it like distal pull of the patella. We reduce it. We do a lot of sutures. Here's a weird one. I think this is a sleeve fracture, but it's not displaced. And so we just treated it with a cast, but almost all these get ORAF. Here's the casted one. And there's a lot of ways to do it. Most of the time you can't get a screw in, you have to do suture. Okay? And you can probably use anchors now too. I'll usually use the little osseous drilling, but with the powerful anchors now, I know our adult sports colleagues for patella tendon have said most of the anchor approach is adequate as well, or good as well. You want to think about you want to try to reproduce the other side. So think about your patella alta, maybe look at the other side, and you don't want to cause baja, you don't want to cause alta. So make sure you look at the articular surface, repair the medial and lateral retinaculum, and consider checking the other side to get the patella height the same. Here's a case of mine, the one that we showed earlier, 11-year-old male, a pretty obvious case. MRI, maybe hit play, let's see what that shows, if this shows anything. Yep, big sleeve, big displacement, huge disruption. We'll go to the next slide. And then that's after suture repair. Here's another 13-year-old. Usually the mechanism's like a jump, eccentric loading. Again, repaired with the transosseous suture. Here's a case we had last year. The quad tendon avulsed and the tibial spine. Give me a break. So the quad tendon and the tibial spine.